Hi, I'm Maggie Lang, and I'm going to discuss the explosive growth we are experiencing in the telemedicine field in this podcast. Remote patient monitoring is information that is shared or transferred electronically between a patient at home and their clinician to assist in the diagnosis, monitoring, and management of a medical condition. In the early 1900s, radio revolutionized communication. Inspired by radio's sudden prominence in every field from entertainment to national defense, it wasn't long before innovators started imagining how doctors could attend to patients over the radio. A radio news magazine from 1924 featured an illustration of a doctor attending to a patient via video call. The headline read, "The Radio Doctor Maybe." At that point, this was only the editor's vision of the future technology, but 90 years later, these dreams would be realized. The earliest transmission through radio wires was the telegraph. In 17 and 1800, the telegraph made it possible to send near instantaneous communications across long distances. Some medical uses of the telegraph was during the Civil War. It involved ordering medical supplies and transmitting casualty lists and medical consultations. And then we have Alexander Graham Bell, who of course invented the telephone in 1876. Much of early telemedicine was delivered via phone communication to patients. In the 40s in Pennsylvania, radiology images were sent 24 miles between two townships via telephone line in the world's first example of electronic medical record transfer. With the arrival of motion pictures and film technology came even more ideas in the medical field to use telemedicine. In 1959, at the University of Nebraska, they established a two-way television setup to transmit information to medical students across campus. And 5 years later, that university linked with the state hospital to perform video consultations. Telemedicine became so popular in rural areas where populations with limited healthcare access could now reach specialists from far away. In the 1960s and 70s, the Public Health Department, NASA, the Department of Defense, and the U.S. Health and Human Service Department all invested time and money for research into telemedicine. One of the most successful of these government projects was the partnership between the Indian Health Services and NASA. The project was called Space Technology Applied to Rural Papago Advanced Healthcare, or STARPAC. This provided both Native Americans on the Papago Reservation in Arizona and astronauts in orbit with access to medical care. Microwave technology transmitted X-ray photographs, electrocardiographs, and other medical information to and from the Public Health Service hospital. Monitoring astronauts from orbit initiated the explosion of telemonitoring and the quick growth of the field as we see it today. Wearables like fitness wristbands and heart rate monitors are an early example of mobile health tools that can track patients' vital signs in real time. We may also be able to identify the first signs of illness, medication compliance, making sure that the patients are taking the right amount of their medication at the right time of day. We can link a remote stethoscope to a device in the home, place it on a patient's chest, and listen to their heart or breath sounds. We can link a scale to a remote monitoring device to follow a patient's weight to make sure they are compliant with a weight loss program. We can use a handheld video camera and ask the patient or caregiver to hold it so we can look down a patient's throat, in their ears, or anywhere else the clinician might want to investigate for signs of illness. We can also have the patient take their blood pressure and temperature and see it in real time. Doctors are using remote virtual visits to monitor patients' vital signs and clinical status. Imagine not waiting in a doctor's office for over an hour and sitting at home in front of your smartphone, computer, or iPad for your exam. There also is a telemedicine app explosion. In certain parts of the country, doctors are signing up for the Doctor On Demand app that you see here, where they can virtual visit with a patient on their smartphone. Patients can be connected in minutes to a doctor and avoid the long wait times in offices. Incorporating remote patient monitoring and chronic disease management can significantly improve an individual's quality of life. It allows patients to maintain independence, it prevents complications, and it minimizes personal costs. Remote patient monitoring also facilitates these goals by delivering care right to the home from a computer, smartphone, or iPad through a secure platform or even an app. We may be able to identify the first signs of an illness or make sure our patients are taking their medications correctly at the right time of day. Improving patient care at home with real-time video conferencing might be a cost-effective way and improve interdisciplinary communication. It may also be easier for patients who have a difficult time getting out of their home into a vehicle to go to a doctor's office or other office visit. Asthma is one of the most difficult childhood illnesses to control. The CDC describes asthma as common, deadly, disruptive, and expensive. The disease places thousands of adults and children at higher risk of missing work or school, as well as of emergency room visits, hospitalizations, and even death. In New York City, 10% of all children have a current diagnosis of asthma. In Brooklyn, New York, asthma accounts for 13,000 emergency room visits in children ages 0 to 17 and 2,500 hospitalizations annually. Asthma incidence in central Brooklyn is among the highest in New York State, affecting 1 in 6 children. Asthma is the leading cause of hospitalization in children in New York City. The New York City pediatric hospitalization rate for asthma is twice the U.S. average and 3.4 times the rate in the rest of New York State. The disease burden of asthma costs New York State healthcare system $1.8 billion annually, the second highest state in the nation. 28% of children with asthma did not have a routine asthma checkup in the last year. These figures are completely overwhelming. Currently, in our agency, we are using a remote monitoring telemedicine device to monitor pediatric patients' compliance with asthma medication. Each of the patient's medication inhalers has a small cap on the tip of the inhaler. If a patient's taking their rescue medication more than the amount prescribed, say every 2 hours or so, and he's not taking his controller every day, a nurse in the office receives an alert and immediately calls the patient to make sure they're okay. If they're not, they're either directed to use more of their medication according to the doctor orders, or they call the doctor or go to the emergency room. It is our hope that we can decrease ER visits and hospitalization rates related to asthma and improve pediatric outcomes and medication compliance with this telemedicine device. The most difficult challenge we have is keeping our patients and their caregivers motivated to continue with the asthma telemedicine program. Some of the issues we face is that they're just not compliant with transferring data from the device cap to their smartphone when they really just have to turn the app on and leave it on. The app automatically picks up when the inhaler is used and transfers this information securely to the data platform in our office. We can also motivate patients to buy in using the social cognitive goal setting theory. Patients and family that set goals and have a sense of self-efficacy for attaining that goal can engage in activities that will lead to goal attainment. This is important during our initiation phase in the home. We do explain to the family and the child that they can get control of their asthma. They don't have to be awake all night, every night coughing. We can help them by monitoring them remotely to help them to achieve better control of their asthma. We put a children's app on their phone so they can better understand asthma and gain more autonomy in the management of their disease. They're awarded points for taking their control of medication as directed daily. It also has games, movies, and fun reminders for them. When the family realizes that the asthma is better under control and their child is happier, then they can participate in school activities, be out with friends, and they don't get tired so easily. The family sees that these goals are attainable and wants to be more of an active participant in maintaining long-term control of their asthma. All of our nurses are trained to enthusiastically deliver an educational asthma program. They use cartoon movies, apps, coloring books, and colorful flip charts to show how asthma control can be attained at home. Some final thoughts. If all of this is able to be monitored at home, why would anyone want to sit in a doctor's office with numerous sick people? or sit for hours in an emergency room with a sick child? What motivates people to take charge of their health care? Why not just log in and have a virtual visit with your doctor or clinician? Why not perform therapy sessions at home with your therapist on a computer screen? Several agencies have already initiated this and are receiving reimbursement from insurance companies. It's a very interesting field. From the very first transmission of patient information over a single wire to diagnosing patients from a distance with a video camera, we have developed the dreams of those early inventors and have applied them in the telemedicine industry. We certainly have come a long way. It is an extremely fast-moving field, and I can't wait to see the technology in the future of telemedicine. I hope this podcast has made you think of ways that telemedicine can improve your patients' outcomes. Thank you.